challenges which people face when they prepare for part 3 examination, or what are the things which brings you down or anybody down? Hello everyone, welcome to this part 3 session. Embark on your MRCOG part 3 journey and a guided path to success. I welcome you all to this session. So good to see my previous part 2 past students, new students, and of course the present part 2 batch. So very warm welcome to this session. Hello, Dr. Aparna. So good to see you.
Hello, ma'am.
Hello, Dr. Suvarna. Good evening.
Good evening, ma'am.
Good evening, Dr. Devika. Good. Very good. So good. I'm so happy to see you all here for the next and the final step, which is part 3. Oh, Dr. Panaya, I missed your voice. I too missed. I'm looking forward to hear you today in the session. Great. Oh, thank you, Dr. Devika. You are happy to hear. I'm really happy to have you here today. Yeah, so we were missing sessions for quite a few days till we finished our part 1 and part 2 preparations. So here we are with the part 3, something new. So as you see the picture here I've put up, you have crossed your troublesome paths and now you are on to a way to the beautiful destination, which is your convocation. So this is the final step to go ahead for the convocation. So that is being depicted in the picture in front of you. So let's see how we are going to progress through that. So first of all, welcome to the MRCOG Part 3 journey. Now, MRCOG Part 3. This is different from your Part 1 and Part 2. In your Part 1 and Part 2 exam, you had your papers in which you have to tick mark the answers and they were written exams. Now this is OSCE, right? So this is your verbal exam. You have to go, you have to present. Go means either you can have an online exam or you can have an on-site exam. Both the options are given by the RCOG depending on which area you are. So it could be on-site or online, but basically the thing is you have to be present, right? And you have to give your exam. So it is not like the written exam. Dr. Shantley, yes, actually they have largely stopped the online exam, but for some seats they sometimes provide for the countries where they are still not conducting the centers. So sometimes in second booking, they do provide some online seats. If they were there till last exam, I don't know for the upcoming exams whether it will be there or not. But till last exam, they were providing some of the online seats, right? But then as I told you that it will depend on what area you are, right? So MRCOG Part 3 is a clinical assessment of knowledge, skills, attitudes, and competencies. So now you see, till now, they were testing our knowledge. Welcome, Dr. Chantle. So this is, previously they were only testing the knowledge. Now they are testing the skills, your attitude, your behavior, your personality, and your competencies. By any way, whenever I use the word personality in this complete presentation, I never mean it about your looks. It is how you behave, how you present yourself, your confidence level, those are included in the personality. Anyway, wherever I use word personality in this whole presentation, please don't take it for the looks, right? So knowledge, skills, attitudes, and your competencies. So let's see how it goes. What are the different things which are tested? But now, till now, you must be knowing that it is something beyond your knowledge, which is going to be tested in part 3. When you have appeared in the part 2, your knowledge is adequately tested by the exams, by those scary EMQs. They are the best way to check the knowledge. So college is happy with your knowledge. That is why they have allowed you to go on to the part 3. Of course, it does not mean that you don't need any knowledge here, but definitely that is just one part. 1/5, 20% of your paper is your knowledge. Rest 80% is other things, right? So large part is other part. So let's go ahead and see what are the other things which we have to do for the part 3. So why MRCOG Part 3 matters? Of course, we know that this is the final step for the award of membership for which we all are waiting here. And of course, if anybody is in UK trainee, then this is the most important because you have to pass this to go into ST6 and ST7. So ST5 has to pass through this. Why I'm telling you all this? Because when you will do your stations, you have to take it as you are ST5, right? So all the competencies which are required by the ST5, you have to believe that you are working till that level. And then you solve that task according to that particular thing. Because just to give you an example why this is important, like in a scenario where to call consultant, right? So it's not that you will have to see ST5 can do the cesarean section of placenta previa. Of course, consultant just have to be informed, but he does not have to be there only. So if there is a task related to that, you can do the cesarean section by informing. No need to say that consultant has to be there. So these things you have to know. What are the powers of ST5? Till what extent ST5 can work? And accordingly, you have to keep in that position and answer your questions accordingly. So you cannot call every time consultant. If you are doing that, it shows that you are inconfident. And if you are not calling consultant when it is required, then you are playing with the patient safety. So either way, it will go bad. So you have to be very particular where you stand, what is your efficacies, what is your efficiencies, and then answer accordingly. Now, what is the real world impact of part 3 on clinical practice? How it really affects you? So I think those who have gone through the part 2, I mean, everybody here has gone through the part 2 journey at least. So you know that how it makes a difference in your academics, how it makes a difference in your viewpoint of looking at a patient, clinical diagnosis, management making, how it makes a difference. Now, what is the impact of part 3 is it's going to completely change the way of your practice. So basically, from your practice table to the beds, the change is going to happen. How your personality, how you come in front of the patient, how you talk to patient, your communication skills, all will be refined. And with all difficult stations, you will be able to manage your tough times in clinical practice more efficiently. So after part 3, you are definitely going to be a very different changed person, of course, in a good sense. So from this practice, from your academics to the clinics, it's going to be a massive transformation. What is the agenda for today? We are going to talk about exam format. What are the types of the stations which are there in the exams? What are the domains tested? And then, of course, as we always work, those who have been with me for last 2 parts, they know that we work strategically, where you can gain marks, how you can gain marks. So understanding scorecard is very, very important again in part 3. Time required for preparation, always a question asked. How many months I'll require for the preparation? What is the recommended reading? What books, what guidelines, what things we have to read? What is the concept of ideal station and how to practice station to achieve maximum marks? So we are going to give you a complete overview today so that you know at what level you have to begin your preparation and what is the right way to go ahead. And of course, if anything else you guys want to ask, I'll be happy to answer those questions too. Now, first, let's start with understanding the exam format. 14 is the magical word for the RCOG. We had modules in part 2, and now we have 14 stations. 14 stations. Usually, one station per module, as it is said, but it is not fixed. You may have 2 stations from any particular module, and some particular module may be missed. But usually it is said that one station per module, but not fixed, right? So 14 stations, 14 tasks you have to do, right? So this is the first thing. So total 14. How it is 14? It is like compartments. You go into one chamber, come out, go into second chamber, come out, go into one chamber, come out, into second, into third, into fourth, into fifth. It is like that. So you come out, go into next, next, next. There is no break. No break. These are the fastest 3 hours of your life. I tell you what I felt personally. The moment I started and when I finished, I was like, oh, I finished 14 tasks and the 3 hours are gone. I was so much surprised. Actually, it was like, where to enter now? After 14 cabins now, where to go? So you don't even realize how fast the time is going. And mind you, just let me know after you come back, wasn't they were the fastest 3 hours of your life? Very, very fast that time goes. And the most important thing is you don't have any watch there. So no timer there. So you don't even realize when the time is passing. Now, how the time is divided? Every 14, these all 14 chambers in a row or in a circuit, like in an area, 14 chambers are created. These are just simple partitions, right? And on the outside of the chamber, on the wall or on the partition, a paper is pasted. 1 paper, 2 paper, or 3 papers are pasted. That is your task. That is your task. You are given 2 minutes to read that task. And after 2 minutes, a timer buzzer rings and you have to go inside into the chamber. Inside the chamber, you will get 10 minutes. Buzzer rings, come out, next chamber, 2 minutes reading time. Again, buzzer rings, go inside. So 2 minutes and 10 minutes, 2 times the buzzer rings. Okay, so like this, you have 10 plus 2 minutes. 10 plus 2 minutes for one station. 2 minutes outside the cabin and 10 minutes inside the cabin. No break, immediately move on to the next. Immediately move on to the next. Like this, no water, no loo, no nothing, nothing. You just go inside the room, start from one room, and you come out after finishing all the 14 rooms. When you enter first, 14 candidates are there in your circuit. So from 1 to 14, a candidate will be starting from one cabin, right? He will be standing, like one person will be standing in front of one, second person in the front of two cabin, then 3 in front of 3 cabin. Like this, 14 people are standing. So whatever cabin you start, like you start from the 3, so you will go 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, and then 1, 2, right? So like this, you have to stop. So these 14 people will keep on going like this in next cabin. So in one circuit, 14 people will participate. Now, why it is important? Because, see, this is a type of competitive exam. Although you don't get any rank or nothing, and it is not like these people are selected and these are not selected. It is pass or fail. But largely, the examiner sitting and one after one, 14 students are coming. So it itself becomes a competitive. Because a person in before you, if he goes and like presents very nicely, tells everything correctly, and then a second person comes in and he tells averagely good, third comes in, he's telling very poorly, so that itself becomes like comparative type of criteria. So although it is not a competitive but a personal human outlook that comes in. So how your 14 students, how the 13 students around you are performing, that will definitely make a difference in your scorecard, right? Although the scoring is very, very much objective, we are going to talk about the objective scoring. But this is what is the human perception. That definitely makes a difference. So your result will be according to how the other people in the circuit are performing. Clear till now? Any confusion? Any questions till now? Fine. So this is the various modules. You are already accustomed to these terms. So from these modules, the various your tasks are going to come. Now, what are the domains tested? How you are tested in this exam? So I said we have a very objective scoring. Objective scoring, actually RCOG does not want that human perception to come in. So they give a chart to the examiner where the points are written, right? What all things are to be expected from the candidate. Now, accordingly, they will mark how much of these points you have spoken. So largely they want to remove this human perception bias. So this is objective scoring there. Now, largely 5 things are tested. What is patient test safety? Communication with the patients and their relatives, communication with the colleagues, information gathering, and applied clinical knowledge. So now you know that why I was saying 20% is knowledge. Because if you take these 5, 1/5 is knowledge. Rest 80% is your patient safety, communication skills, how you are communicating with the patient, how you are communicating with your colleague, or how you gather information, which is largely you can say it as history taking, but it is not actually exactly history taking. It starts from your entering, taking the introduction, giving your introduction. I mean, whatever you talk, setting a stage, history taking, everything comes in a part of information gathering. Because see, when you are in a clinic, a person or a patient comes to you, what do? You talk to them, take the information, the name, the age, what demographics, few important points, and then you start talking about what are the complaints and talk about everything, right? Then you do certain examination, which is not to be done here largely. If any examination is required, you just have to tell the patient that I would like to examine this thing, if at all it is required. And then you have to explain your diagnosis and give a management plan. So it is more or less like your clinic consultation, but here it has to be very systematic and as per the RCOG rules. So your communication skills will be tested here, information gathering, how you take up information from the patient. And finally, when you plan the management, it is about applied clinical knowledge. And out of these 5 domains, your maximum tasks will have 4 domains tested, right? Your maximum tasks, they will be testing you for 4 domains. Now, how the scorecard is, right? For every domain, you have 2 points. For every domain, you have 2 points, okay? So now when I said you, how will you score for the 2 points? Like patient safety. If I talk of a domain, patient safety, there are 10 points for the patient safety. Suppose in that task, if you tell 8 points, they will give you complete 2 points, right? 8 out of 10 points you told, you will get 2 points. If you tell them 6 points, that will be borderline, or you will get 1 point, right? And if you tell 5 points, you are not going to pass that domain, so it will be fail. So there are only 3 scores, 0, 1, and 2. Okay. So if four domains are being tested in a particular task, So maximum number of score you can get is 8 and minimum is of course 0. Right? So this is how a task will be scored. And total, when you combine all 14 stations, then 70 domains will be tested. So this is how it is. Now this scoring system should be very much clear, because now you know that just telling something will not gain marks. Like sometimes we believe that I told the answer to some extent, but it's not going to work. Up to 50% is fail. Okay, so you have to tell at least 60% to be borderline, 1 mark. And if you want to gain good marks, 8 points, right? And this you have to do for all the domains, whatever are being tested in the exam. So what is the importance here is that if you have told all the points of patient safety, you told everything about the patient safety, or 10 out of 10, but your communication skills were not good, so you got 0 in that. So maybe your station won't give you good marks and overall you may fail. So you have to work on all the domains. Now, importance is when you are preparing for your exam, when you are doing your exam preparation, you are doing a task. So you have to focus on domains, whether you are covering all domains or not. If you are not covering all domains, that means even if you have even if you are working on the important points of that station, still you may not score good. Yes, Dr. Devika asks, will you be teaching in the course what points are must to touch upon? Certainly. We'll talk in general about what are the points included, and then we will also talk about module wise. Module wise templates are also there, and finally case wise also. Okay, so that's how it's going to be done. So it is, I'm just focusing on, okay, thank you, welcome. So I'm just focusing on whenever you are preparing, you need to take into account that you cover all the domains. It's not about talking for 10 minutes, right? It is more about covering the important things in those 10 minutes. So therefore, understanding the scorecard is important. Any questions till now? Got this? Okay. So now let's look at type of stations. What are the type of stations? Okay, thank you. So these are type of stations. So what are there are largely 3 types of stations. That is SPT. SPT is simulated patient task, right? Simulated patient task, or I would call it as a role player station. That would be a better word, because I'll be including the role player as your junior also. So SPT is not a good word. It should be called as role player stations. There is a person in front of you who is playing some role. He can be a patient or he can be your junior. If he is your junior asking for something, then that's a teaching station. And if that person is a role player, then that's a simulated patient task. He is simulating the patient. Now, from where does these role player comes? They are usually the people who are either the laymen who want to participate as role player and they are trained for it, or they are sometimes the people from like support groups, or some types of people who are associated with various medical fields like endometriosis support group or something like that. Okay, so they can be from some medical background but not doctors. They are not doctors, right? And they are given a proper training. It is not that he's sitting in front of you and he will create a story whatever he or she wants. No, they have a very fixed format in their hand. What information they have to give, what questions they have to ask. So that is completely objective. So RCOG has made it largely very, very much objective. Okay. So that person to person difference should not be there. So they have a very fixed thing in their hand, and they even know that if you are going out of the way or if you are wasting time, they will in fact guide you. So whatever role player is saying, never think that sorry, never think that why he's saying so. Okay, never just take it lightly. Even if he is again and again asking one question and you are answering it again and again, then also don't feel that he is stupid. She's not able to understand why she is asking again and again. She is asking again and again because you are not giving the answer which should be the answer. You have to think yours or for yourself where you are wrong, rather than thinking about her why she is telling asking the same thing again and again, right? She is asking, she is basically guiding you. Okay, so whatever the role player is saying, take them as your signposts. They are like your guiding stones, and go accordingly. Yes, somebody was saying something. Was there any question? Okay.
Excuse me, ma'am.
Hmm.
Yeah, ma'am. Ma'am, just wanted to ask, like you said about patient safety. What
Hmm.
exactly patient safety points means?
But I'll just come to the broader outline of these all domains
Okay,
in the later slides, right?
okay, okay,
I'm coming to that. Although each domain needs a proper like 30-40 minutes explanation, but I've just
okay,
going to talk about the overview of the domains in next further slides. I'm
okay,
coming. Okay. So basically, this I was talking about the role player stations. In that, there are certain role player stations which are lay examiner stations, right? In your normal role player station, you will have a role player in front of you who can be either a teacher or can be a patient, and an examiner is sitting, right? So you have two people in the chamber. One is your examiner and one is your role player. Now, what is difference in lay examiner stations? They are also role player stations. Patient is sitting, and but there is a lay examiner. Lay examiner means a layman. He's sitting there and he is looking at you how you are dealing with the patient. He has nothing to do with the applied knowledge. He has nothing to do with that. But he is looking at you how you are behaving with the patient, how you are interacting with the patient. So largely the layman marks you for the three domains. That is your information gathering, your communication skills, and patient safety. Right? So he usually marks you for the three things. Now, in your lay examiner station, you have one of your clinical examiner and one you have layman, right? So you are marked on two sides. So if your clinical examiner is marking you for 4 domains and your lay examiner is marking you for 2 or 3 domains, so if I take it as a 7 domains in one station, then you will achieve 14 marks if you have worked well, right? So there are 4 lay examiner stations. They are very, very, very important to pass because they will give you maximum marks. And mind you, lay examiner stations are easy as well. Why they are easy? Because layman can give you marks if you are good at communication. You are behaving properly with the patient, layman will pass you, right? Clinical examiner may look at multiple things. You didn't tell about this, you didn't tell about this, but lay examiner is just happy with how you are talking with the patient and he may give you adequate marks to pass. So lay examiner stations, you have to do it very well. They are the highest scoring stations and they can give you maximum edge to pass the exam. Now, the last part is the structured discussion task, which is just 4 stations are usually there. And it is basically your like case-based discussions. You have cases, you have labor ward management, you have gynae ward management scenarios. which are there, and a consultant is sitting in front of you and he is going to ask you the questions, right? So it is more like, you can compare it with the Viva. Not exactly like the Viva, but largely like that. So it is basically a two-way interaction with the consultant. So these are the 3, or you can say 4 types of stations, because the role player may be SPT, that is simulated patient tasks, or maybe teaching tasks. So these are total 14 stations. Clear till now? So here you can see 4 people sitting here. So this is the patient, this is the candidate, and this is the layman, and this is the clinical examiner, right? So candidate is just interacting with the patient, rest 2 are giving you the marks. This type of scenario you usually see in the stations where the layman is sitting. If layperson is not there, then clinical examiner, patient, and candidate will be there like this. Dr. Devika, you raised hand. You want to say something?
Ma'am, I just wanted to clarify. So they give you 2 minutes to read the question. Then you ask, can you take history of the patient briefly, and then within that 10 minutes you have to even interact and discuss with the examiner about it? How?
No. See, 2 minutes you are standing outside the cabin. You cannot interact with anybody. You are outside the room.
Okay.
The task is pasted on the door or the entrance, right? So you are outside reading your task. Now you, at the buzzer, when the buzzer rings, after 2 minutes, you enter the chamber. Now you start interacting with the patient. And you, in the role play stations, you don't have to interact with the examiner. You are only talking to the patient and solving her queries, giving her, it's I told you, it's similarly like clinic consultation. Like patient is in your chamber and you are taking care of her, asking history, making diagnosis, doing management plan, that all to be done in 10 minutes, and examiner will not intervene. He is just sitting.
Okay.
He is just observing you, how you are doing, what you are telling and what you are not telling. Only in the structured discussion task where you are with the examiner, in that you will directly interact with the examiner.
Okay, thank you.
Okay, got it? Anybody else? Anything else? Okay, so this is how you have to see how many patients, because largely outside it is written that this is a simulated patient task. This is a role player task teaching station. So this is a structured discussion task, but many a times you miss. So how can you just quickly come to know what type of station it is? If there are 2 people sitting there, so that means this is a simulated patient task, or maybe your junior and the examiner sitting there. So maybe teaching task. Lay examiner, no, 4. 4 is including the candidate, but usually there will be 3 people sitting inside. One is your layman, one is clinical examiner, and one is the role player. And in your structured discussion task, only 1 person is there. So looking at the number of persons, you can just come to know, even if you have missed it reading outside. But I'll just tell you that it is always good to do your homework in those 2 minutes, and you have to practice doing that. We are coming to that practice as we move ahead with the preparation. So this is another good question. What is the preparation time required for the exam? 3 months, 6 months, 9 months, 12 months? When should I appear? Very frequently asked question. So one thing is very good, that you should go ahead with the exam as soon as you do your part 2, because you are very much fresh with the knowledge. So as the opportunity is there, go ahead and take your chance, because at least your applied knowledge part is fresh. If you wait for some times, then that all information starts fading away, and then you have to revise. Of course, you will have to revise otherwise also, because a different pattern of reading is required for the part 3. The same pattern of like part 2 is not here. So you have to revise, but at least a bit fresh is there, right? But if somehow your exam is delayed, or you are not getting seat, or somehow you are waiting, it is good to keep on revising the things in between whenever you get an opportunity. Right? So that is your about the when to appear in the exam. Now, usually 3 month study is enough for part 2 preparation. If you can spare 3 hours or so for your exam preparation every day, and in your last 15-20 days, you may like to spend more time, like 5-6 hours even. Okay, but for the beginning 2 months, you can even go for the 3-4 hours, and that is perfect. So 3 months is a good time. And if you think you can't spare this much of time even, then take 6 months at least. And 9 months, though, it's never required. Right? It is not requirement for the part 3. So that's how you can decide. Another important factor to decide is how good you are at your communication and language skills. Like you all know that you have to speak in English, right? So if anybody feels that he needs to be good in English speaking and all those, then those are the extra work which you have to do on yourself, right? So if you are a good at good speaking skills, then you just have to tune yourself for the station. But if you have to develop your basic skills at also, then you need more time. So that way also you can define for yourself at what level you would like to appear in exam. What is the recommended reading? Now, what is important is here is that on one side, you have to revise your previous things, right? Because you have to have that basic concepts in mind. Like you have endometrial hyperplasia station, and you have to tell about the management plan. So you need your information from your algorithm that I'm going to give you Mirena, and after this 3 months or 6 months, we are going to do your testing again, and all these things. So for that, you require your basic information. So of course, you don't have to go into very much details of these, like reading each and every single line and talking about which is most common and which is least common and which one I have to choose. Now you are above all those boundaries. Now you can give all the options to the patient, right? In part 1, what we used to do, you have to fix one answer, right? Which is the best, which is the most important. Now nothing is best. Now you have to give options to the patient. Yes, you will tell that we usually give this, but these are the other options available, right? So therefore, now it is different. You just have to go through major points. Don't spend too much time digging into the GTG nice or top, but these are the only 3 sources which are required for your part 2. And just few points, like when you go to GTG, see what points are important. If I am going to see endometrial hyperplasia, what points in history are important? Like we know that we have to talk about the risk factors. We have to look at the BMI. We have to look whether the patient is diabetic or hypertensive. So this history becomes important when we talk about endometrial hyperplasia. So you just have to write those 8-10 words. These points are important for this particular patient, and your history is over, right? Then here comes diagnosis and management. Diagnosis, you will usually have to go from the patient information leaflets. Because what are these patient information leaflets? Because now here you have to tell everything to the patient. You have to communicate everything to the patient. So now you cannot tell that you have got endometrial hyperplasia. How will you explain this to the patient? You need to have that language, right? So in your womb, there is a lining which gets thickened with time, and there is a possibility that there could be some changes which can be there. So we need to take care of it. So you have to use the language which is patient friendly. And you have to use the terms like womb for the uterus, neck of womb for the cervix. So for these terms, you need your patient information leaflets. So like in your part 2 exam, your GTGs nice were your Bibles. Now it is the patient information leaflets, which is the basic thing which you have to read, right? For every topic, Most of the topics, they have got patient information leaflets. Whatever few topics leaflets are not there, that you can go and search for NHS trusts or the hospitals. They provide lot of patient information leaflets for their patients. So you will get patient information leaflet for any topic, right? So these are how these leaflets seem. It is same like you see your GTG, and they give you a clear information. Like here, they have explained about the PPROM. Your baby is surrounded by amniotic fluid or waters contained within a membrane bag inside your uterus. When the waters break, it is also known as rupture of membranes. Normally, your water breaks shortly before or during labor, but if it happens before 37 weeks, we call it as preterm pre-labor rupture of membranes. Right? So in easy language, you have to explain this to the patient. So patient-friendly language. This is how you have to explain your diagnosis. So you should practice explaining all the common diagnoses to the patients, like how to explain ectopic pregnancy, how to explain your molar pregnancy, how to explain miscarriage. So you need to work on this, and from the pills, you will have to understand what is the how you have to present the diagnosis in front of patient. Now, till now, whatever we have read in the consent advice, we used to talk at 8 in 1000 patients will get this. Now it is, you have to tell them in a easy language. Like you see here, 3 to 4 in 10 preterm births. Right? So these figures you will get from the pills. When you read the pills, such type of figures are mentioned there. And now these are the figures to be remembered. Right? So this all information is to be remembered from pill. So basically, you will use your knowledge of GTG nice and talk and speak in the form of language in pill. Right? So this is the food you are going to eat, but this is what you are going to serve to the patient. Right? What are the recommended books? So almost 5 books are there. Lisa Joel, this is one of the oldest books, but till date, this still holds very important book, and the tasks are very much close to what are asked in the exams. So in these books, all of these books, they give you the tasks, right? And they give you the answer template or the format. So they give you the questions. When in the task, the questions are given. So you can, like, 2 people are practicing. So you take your task and you give the role player part to the other person. The other person will have that information, what he is playing and what are the questions he is required to ask to you. So he will keep on asking, and there will be a two-way communication between the two. So this is a good way of practicing. And then they have given a scorecard like of sheet there, where you can see that how many points you have covered and how many you have not done. So that you can mark yourself accordingly. So all these books, they give the tasks. So this is Lisa Joel. Tawny is one of the old books, but still some tasks are very good in this. Get Through is a quite, I think, 2019 type of book, 1819, but it is also a very good book. Good tasks are there. Then there are another books like Oxford, and this is another book of Conche. So 5 books are there. Lisa Joel is the basic one. You should start with this, right? And then you can go with the Get Through, Oxford, and finally this one. And if you have time finally left, then you can go with the Tawny. Otherwise, these 4 books. So largely what is required is that when you are practicing with your friends, see, part 3 is an exam where you need your study partners. Okay? If you are speaking yourself, like answering yourself, asking question yourself, it is not going to work very well for the exam, because in your mind you already know this question is going to come, so I'm prepared for the answer, right? And the two-way conversation is very much different from one person speaking. So if you don't have a study buddy at any particular time, you can even pick up your non-medico friend, or maybe if you're one of your staff, she can speak English well, you can pick up that. So give her that role player, right? And practice. And if you want to assess yourself, the other person is layman. He cannot assess you. You record your station and then mark accordingly, right? It is a very good practice to record your stations and listen and improve. Definitely the mentor's feedback or wherever you get a chance to present is a very, very important thing. But at least when you are practicing also, do try to record your stations and listen to them. Because basic things you will even improve on yourself. And try to, from the very beginning, try to involve your friends, like 2, 3, 4 people. Because see, everybody is busy. Nobody is going to get the time when you are free, the other person is also free, right? Many a times you are free, you want to do practice, you have got half an hour, you want to do a station, but your friend is not available. So if you have 3, 4, 5 people in your amongst you, then you can see whoever is free can practice. And this is good for everybody in the group. So it is good to make 4, 5 people group, and then whoever gets a chance to practice, you can go ahead. And it is always like it's a speaking exam. So try to speak as much as possible. Don't feel shy. Initially, when you are working on your introduction, when you are working on your history taking, when you are working on your diagnosis, speak in the front of mirror. Stand, speak again and again, time yourself and see whether you are able to speak it nicely, you're in a flow in a particular time period or not. So practice yourself whenever get a chance, do it with somebody. Even if no friend available, do it with any layman and assess yourself. And very good if you get a good group, do extensive practice. That is the only key to success. You have to practice and practice. Reading is important, but practicing in part 3 is more important. Like in part 2, I always say you have to read the guidelines, but you have to do the questions. If you don't do the questions, even if you mug up complete guideline, you cannot pass. Similarly, in part 3, if you have mugged up all the pills, it is very difficult. So practice and practice. Start from 2 stations, 5 stations, 10 stations. And by the time you have exam, you would like to even go for 14 stations practice in a single round. Right? So this is how you have to develop your skills and keep polishing till the last day. These are the dates for the exam for the May. So I don't think we don't have to go into very much detail. You all must be knowing. And of course, the AOT deadline is 25th January, that all of you have received the mails. So everybody is filling that. And then you will get, yes, this is important to tell you that the priority booking window, you get your first opportunity to book your exam. They give you the exam center, which is closest to your address. So, okay, so you see here that deadline of ensuring your home address and email address are 5th February. Why it is so? Because they want to give you the exam center which is closest to your home address. So if you are right now residing in any country and previously you have filled like India and now you want to appear from that country, so you will have to update your address there. Okay. So because you will be then granted center according to the home address mentioned with the RCOG. So that is why you need to update your details. AOT deadline you all are following. Then this is the priority booking where you will get the first opportunity to book the exam. Then second booking window is those seats which are left. Those seats which are left, they will be offered accordingly. If you haven't booked in the first, you can book in the second. Yes. Any question?
Ma'am,
Yes.
does this exam happen, Patri exam happen in India, ma'am?
Yes. This time it is Chennai and Delhi.
Oh, fine, ma'am. Fine.
Yeah.
Thank you,
In
ma'am.
May, it is Chennai and Delhi. Okay.
Thank you.
So it is like this, you will get that opportunity. So if you have one booked in the priority booking, you will get a second booking option by seats which are left. Yes, what Dr. Shantley wants to ask, what do you mean by seats which are left? Okay, so they sent a booking token to 100 people. Suppose I'm taking an example of number. 20 people did not book, either because they did not want to book because of their circumstances, or they don't prefer that station where the opportunity is being given. So they won't book. So those 20 seats are vacant. They will be open in second booking window. Okay. So accordingly, you will receive the links. So whoever is not booking in the priority booking will receive, if any, second option is available. And then finally, the booking window closes on 11th March, right? So this is how the booking process goes on. This is the fees, and you see the amount, huge amount. So better to prepare to your best and then go with full confidence. Nobody would like to waste such a huge amount. Now, what are the common challenges which people face when they prepare for part 3 examination, or what are the things which brings you down or anybody down? So as I said, language barriers, right? In some of the countries or some of the states, people are not using English very regularly. Other local languages are their common languages. So they may need to work particularly on their fluency or on their accent. I've seen people where they have to work quite a lot. They knew everything, but just because of the accent, they could not pass even for 3 attempts. Right? So your fluency, your way of speaking, the clarity with which the role player can understand your language or the clinical examiner can see you. So those barriers have to be removed. If it is there, then those candidates need to work separately on the English speaking skills as well. Ineffective communication. So just delivering a language, is it equal to communication? No. Good communication skills are somewhat different. We will be talking about the good communication skills when we talk about these domains in details in a separate videos. Every domain needs a separate video. So these good communication skills, some of them, for example, like eye-to-eye contact, because that gives a confidence and that gives a thing that you are really talking to a person. Active listening, right? You are listening to patient, you are active listening, you are involved in the listening. You have to show that, you have to give that feel. How you are sometimes you are just not able to explain what you want to say. Okay, so your diagrams can be a method of effective communication. How do you are communicating your things to the patient? Are you checking back that the patient is able to get your language or not, or get your point or not? So these all are parts of effective communication. So ineffective communication, you have a very good English, you are talking everything to the patient, but patient is blank. She is not able to understand what you are saying. So it becomes an ineffective communication. Inconfident, you yourself are panicking, you yourself are in anxiety, and then you are like, oh, I remember everything, but now I am like. So what these type of people, what they do, there is a scattergun approach. What is scattergun approach? They talk about something in the history, 4-5 things they will ask, then they move on to the next. Okay, let me explain how you are. Then they remember, oh, I forgot this history point, go back and talk to it. So it is not a systematic thing. Okay, whenever you remember something, you pour it. So that is not a good thing. So you have to be calm, you have to be confident, and the practice is the best way to be confident. The more you talk, the more you practice, the more confident you are going to be. I mean, you should practice so many times that somebody wakes you up and you start speaking. That should be the level of practice. So that way you will be above all the anxiety in the exam. Then your time management. I always say that if you remove that 10-minute clock, everybody will pass. everybody will pass, because everybody knows how to manage ectopic pregnancy, how to diagnose ectopic pregnancy. With a small, just reading the pills, you can even go with how to diagnose, how to explain this to the patient. But the problem comes when you have to talk everything in 10 minutes. 10 minutes goes very fast. So this time management is a very, very, very important thing. Time mismanagement, if is there, then certainly you know everything. You are very good at communication. You are very nice, but you are not able to do well. Patient safety, always remember, that is the foremost thing, because NHS is always looking for safe doctors, not for intelligent doctors. They don't want the innovators. They want the followers. They want you to follow the guidelines, right? So intelligence, okay, good enough is fine. They don't need scientists, right? But they are looking for safe doctors. Safe doctors is the priority. Safe. Inadequate knowledge, of course, is the thing which is definitely going to give a problem. So this is largely a thing that few people, they just do recalls and are able to pass through the exam. They have some types of patchy knowledge, but then they have to polish it before they go on to the part 3 exam. And of course, as I told you, do not have to go into depths. For the part 3, what is required, just take out that part and read it. So these are usually the points where the people lag, and these are the challenges which brings candidates down, their performance down. So how do we say you have to, what is our approach to preparation? So we are going to talk in 6 steps, right? 6 steps process. I always like to talk about the station in parts, because you have to be good at all parts and all domains, right? So now, first and foremost, your station does not start from the 10 minutes. It starts from 2 minutes outside the station. When you are looking at your task, those 2 minutes are very, very, very important. And these 2 minutes actually pave your path to success. If you haven't used this 2 minutes properly, then you are definitely going to panic inside the cabin. And you are definitely going to go with the scattergun approach. Only if you have done your 2 minutes homework properly, you will be able to very calmly handle your station and more likely to do your station well. Then comes the first thing, that is introduction, setting your stage, or agenda. Introduction and agenda. Then comes the third part, information gathering, in which history taking is the most important thing, but sometimes it includes the examination points as well, like you talk about BMI. So these are also part of information gathering. Then you have to explain the diagnosis. And after explaining the diagnosis, come up with the management plan. And finally, you have to conclude the station. So these are the 6 things on which we have to work step by step. How do I usually do is, first we try to fix your introduction and setting stage agenda. So that has to be repeated till it gets fixed. Then practice of information gathering. Information gathering varies with the modules. So every module will have different template and different points what are to be stressed upon. Like your gynae cases would have more stress on the gynae, while your OBS cases will need more stress on the OBS history. If you are talking about the sexual health module, then sexual history becomes more important. So like this, all modules will have different templates for the information gathering, but the basic things remain same. Then explain the diagnosis. I already told you that with different pills, you have to see how to explain various conditions, and you have to practice that explanation so that whatever condition is there in the exam, you are able to do so. And of course, the management plan from your knowledge of the guidelines. And finally, conclusion also we have to fix. Introduction and conclusion are largely fixed, right? And these 3 things are according to your scenarios. Now this is 2 minutes outside the station. So here I'm just talking about the outline, what usually you have to do. So first thing is who you are, where you are, and to whom you are talking. So how the usually station is, this is a simulated patient task. Miss Rosie, 25 years old, suffering is complaints of heavy menstrual bleeding is there. She has already went to her GP and she has given her a few pills which did not work. And today she is in this gynae OPD and she wants to consult you, right? Now, what is the information here? And you are like ST3 or ST4 in the gynae OPD, something like that written. Okay, now what is the information you have to decipher? You have to see that I am ST4. I am sitting in the gynae OPD, right? And I'm talking to a patient. She is 25 years old who has already been to GP and tried certain treatments, right? So who you are, where you are, and to whom you are talking. Sometimes they also give you some details about the patient that BMI has, so her GP has mentioned that she has a normal BMI and she does not have any medical concerns. She is medically fit. So sometimes these types of points are also given. So this is what you have taken from your task. Now comes your task. What is your task? She has come to you for further consultation for options of management and you have to answer her concerns. So your task is to go ahead from the first line things already she has taken some pills or something and now you have to move on to the next step, what you have to do for her. What are the domains tested? They will mention. You will be tested on information gathering, communication with the patient safety, or applied knowledge. Usually 4 domains, right? So, or any of like applied knowledge, instead of that, they may mention communication with the colleagues. Like this has been mentioned. So you will be tested on this. So now you have to see what are the domains being tested because you have to be particularly working on those domains. Now, when you see that your task is about HMB, now immediately you create a 4 columns, right? What are the points to be included in patient safety? What are the points to be included in HMB in your history? What are the points to be included in your communication, or what else colleagues you are going to involve in this, if any required? So like this, you have to immediately make a outline. Now, if you have made that outline, you are okay. You have just wrote one word. That's it. Nothing much. You don't have to write a complete thing. You can't do in 2 minutes. 1 minute you have to read and simultaneously jot down your points. And this is a practice which you have to do every time when you have a station. Okay, every time when you have a station, do a 2-minute timer and start practicing. Initially, don't put a timer. Initially, just try to jot down the points. And once you are okay with that, then put on a timer. At least 1.5 months before the exam, start putting this 2 minutes timer. Every time when you practice your station. Now, how the time distribution for the station is? Largely, I've already told you 2 minutes outside the station. Now, what you have to do for the next 10 minutes? I've created this for the 9 minutes. 1 minute I have left because that you will be anyway like going beyond the limits in any of these things. So at least try to be in a 9 minutes so that you finish in 10 minutes. So 1 minute introduction. 1 minute introduction and setting agenda. 3 minutes for the history taking. And I tell you, this is the part where most candidates fail. Okay, because many a times it is up to 6 minutes, you are just taking the history. And then you don't have enough time for diagnosis and management. By the time you reach management, the station is over. You haven't talked about the management. How can a person give you marks in all the domains? Very difficult. So this 3 minutes history taking is the biggest challenge for, I would say, more than 90% of the candidates, right? So we have to work extensively on this. It could be from 3 to 3.5 minutes, but not more than that. 1 minute to explain the diagnosis. Now you know why I was again and again saying you have to speak and explain the diagnosis. You can talk about explain ectopic pregnancy very well. You can draw a diagram, explain that here is the ectopic pregnancy. But are you able to finish in 1 minute with the complete information? That is most important. So timing is very much important. 3 minutes I'm keeping for the management, right? So you may have 1.5 minutes for the diagnosis and 2.5 minutes for the management, something like that. And finally, 1 minute for the conclusion. Like this, you have to time your various parts so as to cover everything properly. So from the very beginning, make it a habit. Like when you are practicing introduction and agenda, don't just practice how to speak or what points to be covered, but also see in whether you are able to do it in time or not. 1 to 1.5 minutes, it should be over. If you are going after 1.5 minutes, then you are spoiling the next all things, right? So do this. Now, the very important thing is if you are practicing like this, okay, if you are practicing your history taking module wise, sometimes some stations come as very odd stations which you have never read before. Okay, you have never read that condition before. Some very vague type of thing comes in the exam. Don't panic. You know that your applied knowledge is just 20%, right? 80% is your skills. Now, these stations are meant to be tested like that only. They are meant to be tested for your communication skills only. Ma'am, an explanation in management, the examiner will interrupt and ask us question. No. No. You are with the role player will ask questions. No examiner. Right?
Okay.
So here, so what I was saying, yes, for the new stations, the main things of setting agenda that are fixed. 3-minute history taking, you can do according to the module. Whatever that odd station belongs to whatever module, you can go ahead with that, right? So 3-minute history taking will be according to the module. So you can go till part. Now for diagnosis, you are not very sure about it because that is a very vague condition. But whatever you can explain, and whatever management you can think of, right? And then you can obviously give a good conclusion. You know that there are certain pills available, there are certain support groups. This all you have to tell. So out of these things, at least you are able to take care of 3 things, right? So you can pass your station borderline. If you have prepared it nicely to this pathway, you will be anywhere in your vague stations also, you will be doing it borderline. So if you are doing in a structured way, then you are even prepared for a very odd stations as well. Now coming to the various domains and just giving you a brief outline, because as I said, because every domain needs a proper session for that. So I'm just giving you a points what all you need to take care of various domains. Information gathering is largely focused on history taking. Again, the time limit, that is the most important thing here. Relevant questions should be asked. Okay. What do you mean by relevant questions? Like if it is HMB, the questions related to that only. Not going very much on the outside about very different things, not required. Secondly, if it mentions that the patient has no medical concerns, then no need to ask again and again. When you are just summarizing, you can say that, yes, as your case notes say, you don't have any medical disorder. I'm right. Or you don't have any medical problems for which you are taking any medications. Am I right? Yes. Finished. So that knows your presence of mind. That tells you that you have read your station properly. While if you go and ask, okay, I would like to ask whether you have any medical conditions requiring any medications regularly. No, she'll say no, but examiner will note that you have not read it outside and you are asking it here. So that all presence of mind. So relevant history taking. Structured, fix a plan. Fix a plan, like I have put up here. Presenting complaints, followed by obstetric history, gynecological history, contraception history, sexual health history, cervical screening history. Now, this is a template, right? You have to go by this sequence. But in your gynae cases, gynae case will come above the obs history, right? As I said, when it is related to contraception problem, then contraception and sexual health history will come up. If your patient is less than 25 years, there is no role of cervical screening history. Like if you are looking at a patient of 23 years and you ask her, have you done your cervical smears normally? Normally, cervical smears is a safety point, patient safety point, right? So it immediately comes to the mind, yes, you have to ask cervical screening because we are very much bothered about the patient safety because that is the domain where mostly candidates fail. So it immediately comes to the mind, oh, I have to ask about cervical screening. But then what? You are asking this to 23-year-old girl. So rather than making any good, it is going to make bad, right? It's going to actually deduct your points. So these things you have to take care of. So therefore, the words relevant, structured, mostly now they ask targeted history because they give you basic things. She has not undergone any surgery. She does not have any medical problems. So they have already given you a background. So you can skip those histories. Don't repeat questions. Don't ask any question again and again the same thing in a different words. Use patient-friendly language. No medical terms. The more medical terms you use, the numbers will get deducted. Use open questions, right? Can you tell me about your problem? Can you tell me about your concerns? Rather than, okay, you have a heavy menstrual bleeding? No. Or you have more bleeding in your periods? No, this is not the right way. Can you tell me about your problem? Right? So she will come up with all the history and your questions will decrease. These are the tricks how you can save your time in history taking. With history taking, keep differential diagnosis in mind. Like a patient of early pregnancy with spotting. So what is the differential diagnosis? She can be miscarriage, any type of like threatened, or she can be ectopic, she can be molar pregnancy. So keep all these things in mind and ask your questions accordingly. Fix your format. Each point is important. Even with good history and communication, you can pass with the borderline scores. If history not good in most of the stations, it is difficult to pass. There are many hidden stations, like a patient is a morphine addict, right? Now you did not ask about the history of drug intake or history of use of any these drugs, then you don't know and you missed it. And that was the basic point of the question. They haven't written it outside that she is a morphine addict. But when you go inside, you have to ask her, and in the history, she will come up with this point. Oh, now this is the station. From your outside task, you see that patient has come for the booking visit. Of course, there will be some point like she has come for late booking. Okay, she has come for booking at 16 weeks. Usually the booking visit is at 10 weeks. So they give you a clue. Something is wrong here. Now, domestic violence patients also come late. So you are focused on that. You are asking about the domestic violence and you see that everything is fine. You don't find any high risk factor, but you left talking about the drug history. Now you don't know. So you did not even touch it. So you did not touch it, so you did not perform your task. So it is as good as not taking up a station. So all your efforts wasted. So there are hidden agendas. So if you don't ask the things properly, you may miss history points. And when you miss the history points, you may not perform your task adequately, which is required. So taking history gives a good foundation stone, lays a good foundation stone for your station. These are the various headings through which we go through when we talk about the history, and there are the various ways of asking those histories. Communication with the patients, very important to pass the exam. Lay examiner stations are highly dependent on this domain. Use patient-friendly language. always ask her main concern, why she is bothered, right? Why she is here. So, because that is the main thing you have to see in your clinic also. If you see, you usually ask why she is bothered. Now you try to read that properly. So, similarly here, check what she already knows before disclosing any results of investigations. This we will talk of in detail. It is like, I mean, when we do the further details about these domains, we'll talk in details. But right now, just to give you an idea, like the report she has brought is of missed miscarriage. Okay. Now you have to see whether she already knows about it or she does not know about it. Because if some of the stations actually she might be knowing, and the station is more about the management. But some of the stations where she is not knowing and the station is more about the breaking bad news. Okay, so that will make a difference. So always remember to first ask what she knows about her investigations. Be empathetic, very much sympathy, empathy. That is a very, very important. It's more like a drama you are doing on a screen. So that has to be there. The ups and downs of your voice, the way you are speaking, the way you are delivering your dialogues is very, very important. It's not that you are saying that I'm sorry, but you are like a robotic language. I'm really sorry. So you have to bring that ups and down in your language. Don't say it should not sound like a robotic. Offer concern whenever she mentions any problem. Offer apology if you are asking about some painful past, like a patient of recurrent miscarriage. You want to take her OBS history. You need to, you don't have to be direct. I want to know about your previous pregnancies, what happened. No, you know that it's a traumatizing for her, so you have to talk sympathetically. I know it would be very difficult to go back and think about that. I'm sorry for that, but it's important. So let's talk about what happened in your previous pregnancies. So you need to talk with apology, empathy. So these things right now, it might be like you find it very odd, but when we talk about the stations, when we talk about the modules, we fix those statements. So in any of these things scenarios like FGM, where you have to go back in the past and talk about it, same language you will use there. So these sentences now ultimately with practice, you have to fix them. Whenever such situation is there, take out that sentence and use it. Okay. So it's like storing these type of dialogues in your memory. Whenever required, take out that sentence and tell to the patient. So that is why practice is more important. Don't interrupt her in between. Okay, if she is telling you something, don't stop her. Listen to her questions. She knows where marks are. Whatever she is asking, explain her, right? Because there the marks are. Even if you have told a complete guideline of ectopic pregnancy to her, but you have not answered her concern, no marks. You can use diagrams to illustrate the things, check her understanding. Like what I said, you have to keep checking whether she is able to get what you are saying or not. Communication with colleagues. I find it very easy always, but still there are a lot of candidates who fail in this also. Okay, so it's good to make a list. Like if you have a infertility station, you have to refer to fertility specialist, or you might need to refer to andrologist. So these types of things you can create it module wise, and accordingly you can just tell wherever the patient needs to be referred. So always remember the theme of communication with colleagues is there, is that you are not the one person who can do everything, right? In India, we are very much accustomed of doing everything on our own, but we have to come out of that bar. Okay, so we need help. We are humans. We need help from the team. So always remember teamwork. So whatever work has to be designated to nursing assistant, like taking vitals. Although I might be taking my the blood pressure of the patients in the clinic myself, but for exam, nursing assistant will take the pulse, blood pressure, and do everything. So you have to assign the work to proper person. right? Always examination in front of chaperone. Wherever required, involve consultant. Wherever required, offer psychological support. Like a patient tells you, I'm really having this bad days with the bleeding and it is really affecting quality of life and I am really going through tough phase. Offer psychological support. It is not a part of treatment, but she is in a problem. She is not feeling well. She is mentally disturbed. Psychological support. Teaching stations, very important for communication with colleagues. They are the stations which are based on communication with colleagues. So now if you have to tell anything about like the student junior has done anything wrong, how to explain that, how to tell him without making any bad impression on it. So that's how it is. Bullying, these domestic violence, FGM, they are largely dependent on this particular topic. Maternal medicine, MDTs, oncology, where you require involvement of MDTs, you have to talk about the complete team, right? Who all are going to be involved. You are not the one to take the decisions. So communication with colleagues will involve that all things. Applied knowledge, no need to tell about that. You all know very nicely about it. Interpret investigations and give management plan according to guidelines. Recognize the risk if you see any alternatives to reduce the risk. Justify your investigations. Risks and benefits. One very important thing is that here nothing is like this is the best, right? Even if the patient asks, okay, just tell me which is the best method for me. No, this is a shared decision making. NHS works on shared decision making. So that has to be a shared decision between the clinician and the patient. So I can tell you the risks and benefits of all. I can answer all your questions, but final decision is going to be your decision. Many a times role player asks such type of questions. Can you tell me which is best for me? No, I'm not the right person to do so. I can give you the maximum information. All your risk benefits, this is what, now you take the decision, right? So these types of things are required. Confident approach, and of course this is a main component of your structured discussion task. When you are discussing a task with your consultant, then of course the applied knowledge plays a major role. Patient safety, now very important. Patient safety starts from the point you enter into the chamber, because you have to check whether you are talking to the same person who is sitting there as the name mentioned outside. So when you are outside, you have to note down that name and age and check the same person is there. Because if the same person is not there, then the station is absolutely different. It is about confidentiality. You cannot talk to that person about any of the details of the patient, right? So good way is to, am I talking to Miss Rosie? Yes. Okay. So, or if you want, can I know your name? So that's it. So your patient safety starts from the moment you enter the chamber, right? Like suppose a person sitting in front of you, she tells you, no, I'm not Rosie, I'm Rosie's sister. Station, okay, that's the station of confidentiality. I cannot share. She will ask you hundreds of questions. Okay, there was a report, they told that there is endometrial hyperplasia, the lining has thickened, what could be done for her? I'm here to discuss that. I'm sorry, I can't discuss that without the permission of Miss Rosie. I need either her presence or her something from her which shows that yes, I can tell you the explanation. And then if she says that yes, she has given the permission, I've got the required documents, then fine, you can answer all your questions. No need to look for the documents. You have to trust your role player. He's not a odd person anywhere in the society. He's been trained for that. So if she is saying yes, and similarly this happens in the sub-fertility stations, where she has like, there is some problem with the semen analysis and the male partner is not there. She is talking and asking that, can you explain me about the semen? No, I can't, because I don't have, this is the report of Mr. That. So without his permission, I cannot talk. I'm his wife. No, I still cannot talk. It is a matter of confidentiality. If she says I have that like required permission, you can tell me, then you can go ahead. So patient safety, it's in very many forms. Drug allergies is a very common thing. Medical history to rule out contraindications. Like you are prescribing HRT and you missed a history of breast cancer. Patient safety. Check name and age on reports. Okay. The reports provided to you, are they of the same patient? So how do we go about with this? Whenever you have any report in front of you, always, whenever you get a report, okay, this is Miss Rosie, 25 years. Yes, right, this is yours. Examiner knows you have checked it, right? So that means you have done that point for the patient safety. Confidentiality, I already explained you. WHO checklist is very important for all surgical procedures. Mentioning about the WHO checklist is very important when we talk about surgeries. Incident report. What are the various obs and gynae indications where you have to fill the incident report? That is another important thing. You cannot miss that. If you miss, then it becomes very difficult. Rather, there are 4 Ds, like you have to tell truth, you have to document. So these things we will talk about when we do the various stations with the clinical governance in action. Safety advice, give her emergency contact numbers. She has to come back. If she gets fever, or if she gets bleeding, she has to come immediately. This is the number where to contact. Giving information leaflets, giving complete, because as I said, we are doing shared decision making. So giving information leaflets is also a very important point for patient safety. If any drug is used in unlicensed, like we use nifedipine, this is unlicensed in preterm labor. So you have to tell, I'm giving you this, but this is unlicensed, but this is routinely used in hospital protocols. Would you mind using that? Right? So you have to check. You have to tell her that this is unlicensed, but still we are prescribing. If she doesn't mind, she can use that. Involve consultant and other specialties wherever it is required. So various patient safety features, they come into action depending on, like a very common task of episiotomy, right? Episiotomy, giving an episiotomy, suturing. Very common safety point is checking for xylocaine sensitivity and keeping your crash trolley ready, right? So whenever you give xylocaine, you have a chance that she may have anaphylaxis. So your crash trolley should always be ready. Now, this is a very important safety point. You miss it, you will miss the marks. So like this, there are specific safety points for specific stations. So how do we go about it, or how do you have to go about it? Like first is we will understand these domains in more clarity in general. And then whenever we start any module, we'll talk about the common things in that particular module. And then we make a list of stations. Like in early pregnancy, there are 12-15 stations which can be asked in exams. And then try to create templates for them. Templates, you don't have to write very much in long, because already you know that 1 minute, 2 minute is there for you. So just points. History, these points are important. Diagnosis, this one line I'm going to tell for the diagnosis. Management, these 4 points are important. Out of these points are going to come in safety. These points are going to come in communication with colleagues. And like this, you define 4 columns and finally a line of conclusion and finish. Not more than 1 page of your notebook. For one station, 1 page of notebook, just points. That's all. This is the way how you are going to prepare your templates, or how we are going to provide you too. Okay, when we go through the course, we keep on providing you these templates. Okay, so like this, you have to go ahead. So that finally, when you are nearing the exam, you just have to focus. You practice the case with your friend, listen to it, just see your 1 page in the notebook, what you have missed. Accordingly, you can mark yourself, right? So that is the way to go about for the exam preparation. So basically, knowledge with personality development, communication, and time management will give you the required success. So that was about the overview. Now all your questions are welcome. And definitely I would like to hear your feedback too.
Ma'am,
Yes.
regarding this, speaking to the patients and all and assessing the patient's competence, if we have a minor patients like assessing the glyco competence, if we have some minor where we feel if that person that patient does not have a glyco competence, how do you go about that?
Okay, so if the patient is not having competence, then you have to refer that patient to the team who is going to assess that patient in the so you have to tell her that I'm referring to some specialist doctors. They would like to assess or talk to you, and then accordingly we'll start the further treatment plan as they advise.
So we'll be like communicating this to the patient that yeah, I'm not the right person. So we'll have to take a second opinion and then we'll have a management plan.
Yeah, basically it is not the way. You don't have to say that I'm not the right person, but the way is that you have to say that we need help of some specialized team in our setup, and I'm referring you to them, and they will take care of you for the further. And once they assess and do all your basic requirements, then we'll plan the further management. For now,
Fine.
if you want, I can tell you. If you want, I can tell you what all management options we can do. But finally, after their assessment only, we can go ahead. Now, if she wants to know about the management options, if there are marks for the management options, she'll ask, okay, please let me know what are the options. And if there are no marks for that, the marks are only for the referral, then she'll say, okay, I don't want any further information right now. I'll come after the assessment.
Fine, ma'am. It's all like it's our assessment and our perception. If we feel that the patient is not competent enough, we'll have a second opinion.
See, competent enough is a word basically. She will behave like that. She will. The scenario will be created like that you will come to know that she is not competent. Okay.
Fine,
Usually the teenagers are like, there is a different way of handling them because teenagers are a bit difficult to address. Like they will not give you a history in a proper way. So that could not be usually not be a scenario of not being competent, but rather requiring specialized communication skills. Right? So there you have to weigh the difference because not having competence is not very common station, but requiring specialized communication skills for teenagers is a common thing.
Ma'am.
Yeah.
Right. Thank you, ma'am.
Welcome.
Excuse me, ma'am.
Yeah.
Ma'am, like you said that you can always draw and then explain. So in general, we actually have to draw and explain, or just we have to do the acting of drawing and.
No, no, you have paper pen in your hand, so you can just line draw, line diagram. Just make a uterus like this, do tubes, ovaries, finish.
Okay, okay. So we have to draw.
Yes, yes, you have to draw.
Okay, okay. Thank you, ma'am.
Yeah. When you do your online exam previously, then it was like doing acting or saying, but when you are in front of the patient, it's always good to draw a line diagram. Not beautiful. They don't look at the beauty. It should be explanatory. Like patient should be able to get it. Yes. Thank you, Dr. Devika. You find it useful. Good. Thank you. Yes. Any more questions? Okay. So shall we finish this session? And of course, the enrollments are open. we will stick to our ensure success in 70% less study time, unlimited access and top library access, everything. QR code is here, so it can be scanned and enrolled. Okay, thank you, Dr. Aparna. Very nicely explained as usual. Thank you so much. Okay.
Thank you so much, ma'am.
Welcome.
Thank you, ma'am.
Thank you, ma'am. Thank you,
Good
ma'am.
night.
Thank you everyone for joining. Bye bye. Good night. Take care.
Good night, ma'am. Thank you, ma'am.